Hi, everyone, and welcome to the SRHM podcast. My name is Nina Sun, and I'm an associate editor for the SRHM Journal. Hi, everyone. I'm Nina Sun, an associate editor of the SRHM Journal. In this episode of the podcast, we hear from two authors of a recently published paper called Access to Assisted Reproductive Technologies in Sub-Saharan Africa, Fertility Professionals' Views. Andrea is a professor of anthropology at the School of Social Sciences at Monash University. Trudie is an associate at the Amsterdam Institute for Social Science Research at the University of Amsterdam. Their paper is a qualitative study involving interviews conducted between 2021 and 2023 with 19 fertility specialists, 11 embryologists, and one clinic manager from South Africa, Zimbabwe, Namibia, Kenya, Ethiopia, and Uganda to explore issues surrounding access and potential low-cost IVF options. The study was funded by the Australian government through the Australian Research Council. Trudie and Andrea, thank you so much for taking the time to be with us today. Trudie, can you speak a little bit about the rationale or knowledge gap that this article speaks to? Why was it important to publish on this topic?
So thank you for asking this question. By now, the impact and the social consequences of infertility in sub-Saharan Africa is quite well known and documented. However, much less is known and especially published about what is actually being done to tackle this problem. While people working in the field of infertility all know that hardly anything is done about it in the region, not to prevent infertility, not to destigmatize it, nor to treat it. And while the number of IVF clinics in the sub-Saharan Africa region is increasing in the last decades, especially in the private sector, these clinics are not affordable at all for most people who need it. And that is one of the reasons why we started this study. We wanted to picture how IVF is being offered in sub-Saharan Africa and the different kinds of mobilities that are involved in this, both from the side of the providers, the users, but also gametes are traveling around. Gametes, that means the ova and sperm that are traveling around as part of this developing IVF industry, as we call it. In our conversations with the specialists, especially clinic directors, gynecologists, embryologists, we also spoke about possibilities to offer low-cost IVF. And the results of these conversations is what we brought together in this current article.
That's a really insightful answer and explains a lot. I'll move on to the next question. Could you tell me a bit more about the specific findings that stood out to you personally? Andrea, please go first, followed by Trudie.
Yeah, sure. Thanks very much. I think on this study, one of the things that really stood out for me was that although we know that there are a number of low-cost IVF programs, one of which is the Walking Egg program that's very famous, what really stood out was the level of debate and contestation that still exists across sub-Saharan Africa about such initiatives. In particular, I think it was quite shocking that there's enormous human resource limitations across sub-Saharan Africa in terms of embryologists and also fertility specialists per se. And so a lot of those low-cost programs depend upon embryologists for those interventions to work. And this was time and time again pointed out as a real limitation to making assisted reproduction more accessible, let alone more affordable for people. The other thing I think that really stood out is that different clinics are all trying, everybody really agrees that access is a problem. And so there was almost universal agreement that there needs to be something done across sub-Saharan Africa to make assisted reproduction more accessible for the people who really need it. And yet people differed as to whether they felt it was a human resources problem, whether it was about having laboratory, access to laboratories for sort of mobile low-tech incubators, or whether it was about having labs on trucks, or whether it would be about wealthy patients subsidising poorer patients. And then people talked about medications as the third arm that could improve access by lowering costs. And this involved things like low stimulation cycles, or using conscious sedation for removals rather than anaesthetists for oocyte pickups. But very few of the specialists ever mentioned the cost of pharmaceuticals as a real barrier to getting the costs of ARTs, or assisted reproduction technologies, down. And that to me really sort of stood out as one of for me, what's a fairly obvious area to work on would be the cost of the drugs involved in assisted reproduction, and the role of pharmaceutical companies. And yet this was something that was not highlighted by the specialists. And I don't know, Trudie, did you have something that stood out for you?
No, I think what you were saying is actually also very much my impression and what we learned in the field. And this continues to be concerning. And I'm not sure if you already mentioned this. Maybe you could leave this out, Aditiri, but in case she has not mentioned it, it's what I found concerning, that it seems that quite a lot of profit is being made in this sector, both by the pharmaceutical industry and by some of the private clinics. And when being there, when visiting these clinics, you sometimes wonder whether it would be possible to make a bit less profit and give a bit more people the chance to also make use of these IVF treatments.
And I guess the other thing that stood out, I suppose, is the huge disparities between the public and the private sectors in terms of assisted reproductive clinics. Just the equipment, the surroundings, the personnel, the lab time, access to operating theatres. That's really very obvious that the public sector and public health system is really not capable of serving the needs of the very great needs of the populations across the region.
And maybe having said all this, so in another article we published, or we are about to publish, we also went into the motivations and into the backgrounds of especially of the embryologists involved. And in this article, we are a bit critical, of course, about some of their attitudes, but we also notice that many of them are really extremely committed to get these kind of treatments closer to the people. It's not that these are all greedy people and want to become rich. Many of them also are very concerned about infertility issues and are confronted with them also in their own circles, and they know how important it is to resolve it, to tackle it. And so they are also very eager to work in this field to improve the lives of people who are affected with infertility.
Thanks very much, Trudie. And this kind of ties into what you said before. So if you still have something to add, I wanted to ask both of you, where do we go from here? What do you believe are the next steps now that we have this evidence?
Yeah, sure. I think this is sort of the beginning of what needs to take place as a much broader dialogue across sub-Saharan Africa about really making assisted reproduction accessible and affordable for the people who need it. And so essentially a dialogue to really think about providing reproductive justice for people suffering from infertility in the region. The next steps, I think, really clearly, very few countries have regulations regarding assisted reproduction, so we need that sort of infrastructure set up. We need greater emphasis placed upon low-cost treatments and more studies that actually evaluate the efficacy and safety of low-cost treatments, because there's still considerable debate and sort of mistrust of some of the low-cost interventions that do already exist, and really the need for more fertility experts, in particular the training of specialists, of primary healthcare infertility specialists as well, and of course embryologists. So this is a fairly limited study as a qualitative study, but I think it points to the need for those decision makers, which essentially are the fertility specialists across the region, to actually take this issue up and start to advocate and think very carefully how best they can be involved in helping ensure reproductive justice for the population. Trudie.
Yeah, thank you, Andrea. You pointed out to the important next steps. And in particular, I think I want to emphasize the importance of having more studies done in this field. And given the manifold uncertainties about the actual results of various low-cost initiatives, I think first place we need medical studies. We need medical studies that really look into the results of various low-cost initiatives. That is number one, I think. And I think maybe it's good to mention also one of the studies that's actually at this moment being undertaken in South Africa by Gerhard Boshoff. He is a PhD candidate at Steve Biko Academic Hospital. He's working there as an embryologist, but he's currently also doing his PhD in this area. And together with his supervisors, he has developed a truck that has a mobile laboratory. And their idea is to go around with this truck in the rural areas of South Africa. And then they collaborate with a number of, and that is the good news, with a number of private clinics. And then in combination with these clinics, they could offer full IVF treatments at more faraway sites, far away from the big IVF centers. And they will be able to offer IVF for lower prices. And as part of his PhD, Gerhard Boshoff is involved in offering these treatments, and he will follow up the results, and he will also present that in articles. So I think this is the kind of evidence that we need to really be able to make the first step. And this is just one initiative, and I think it would be very recommendable to have more studies also testing, implementing different sort of low-cost initiatives. That is the first kind of study that I think is very important to be developed. Secondly, I think it's important to follow the introduction of these low-cost initiatives with our kind of studies, with anthropological studies that look into all the contextual details that may have an impact in the way these low-cost initiatives are being offered and being accepted and resulting in hopefully positive, but maybe sometimes also negative results. So I think the combination of these studies would be the next step in this field, next to the more policy-like recommendation as Andrea suggested.
Can I just add one little bit to be fitted in at some point? Look, I think one of the other unique things about this paper is that as anthropologists, we haven't sort of taken someone else's definition of access, but we've been asking people on the ground what they regard as access or what they regard as low-cost interventions. And I think that sort of study is really useful because access means many different things to many different people. And I think that's what comes through in this paper as well, is that when we ask people, well, you know, is your clinic, how do you feel about low-cost interventions, or how do you feel about improving access? What do you do? Do you do anything in terms of that? Then you start to see these very different ideas around what they think access involves or what would make things low cost.
Thanks very much, Trudie and Andrea, for this insightful and informative conversation. It was really great speaking to you both.
Thank you.
Thank you.
For our podcast listeners, you can find a link to the paper in the show notes. Thanks. Thanks for joining us for this insightful conversation. Please check the show notes for a link to the SRHM journal, which is available online and open access. Follow us on social media and sign up for our newsletter to receive notifications for new publications. If you're enjoying this podcast, please subscribe, give us a rating, or leave a review. Sharing evidence-based and rights-grounded knowledge is our passion, and it's also critical to support the advocacy and actions that need to be taken to improve SRHR for all. We would very much appreciate it. Thank you for supporting the SRHM podcast, which is produced by our staff. The music was composed by Tiber Christian and Salomon Beautond.